And it gives me great pleasure indeed to launch today a very important publication and a very useful publication that Cope Foundation and Kathy and Jenna have written with the assistance of many people from the organization. And I'm just going to briefly share my screen now and talk you to share this great present publication with you. So it is a publication around living life with dementia and practical approaches to care. And that's what our particular webinar this afternoon is about. I'm very much drawn from this really good publication which Cope has produced. Oh, apologies there. So this is a guide to dementia care for people with Down syndrome and who have got an intellectual disability. I have found this a really, really very practical guide, really to support anyone who's caring for somebody with dementia, with Down syndrome, or indeed with any type of an intellectual disability who are at risk or indeed who have dementia. And I really want to congratulate the authors of this really important publication, Jenny and Kathy. This is a publication that's beautifully laid out. It's beautifully put together. It focuses on a range of topics, including the unique signs and symptoms of dementia in people with Down syndrome or ID, screening and diagnosis, areas which we covered last week, key information in relation to pain management and medication, and then practical strategies in supporting a person to maximize their daily living skills, communication, and the environment for as long as possible. And many of these topics, particularly around communication and the environment, we will be covering again in future masterclasses. But as I just to congratulate both Jenny and Kathy, they're healthcare professionals and they have established the Dementia Care team in Cope Foundation. And I'm not sure if people joining us internationally are aware that Cope is a non-for-profit organisation in Cork and it supports over 2,500 children and adults with intellectual disability and or autism. And I think I really want to congratulate the Cope Foundation for the support that they have given for the development of this really important publication and important resource. And I think it is a real credit. I also want to thank on behalf of Jenny and Kathy, the other members of the Dementia Care team at Cope, both past and present, and who have contributed greatly to this publication and whose knowledge and expertise really were fundamental to the creation of what it really is a wonderful text. And we have a list, I'm not going to read those, but there's a list of all of those people here on this slide. So well done to everyone. But I think the real stars of this publication that I really do want to mention is people who are with us and some who have passed away. But it is, I think, for all of us, it is the people that we support that really were the inspiration for this book. And I think that's what makes it such a beautiful publication. And really a special thanks to all of these people who supported it and are featured within the book. Particularly, we would like to remember at this time Liam Coughlin, who has passed away and is no longer with us, and Adrian Jones. And our thoughts are with Liam and Adrian's family and staff who supported them so lovingly during the final stages of their dementia and of their lives. And Samantha Dalton and James Drennan and Ita O'Brien, Kieran O'Brien, Yurka Ronan, and Arthur Russell. Oh, and apologies, we also had Mervyn Sweetman, who has also passed away. And we remember Mervyn and his family and staff again at this time. But I think they are the real stars of this publication and have been the total inspiration behind the book. So the National Intellectual Disability Memory Service, as I mentioned previously, is a partnership between the Trinity Centre for Ageing and Intellectual Disability, Trinity College Dublin and Tallaght University Hospital and the Daughters of Charity Disability Support Service. And it's supported this new initiative has been supported by the National Dementia Office and the Department of Health. And it really is trying to share the expertise. And as I said last week, many services a number of services are well resourced and have really good MDT teams which are able to assess and support people who have dementia. Others don't have that, have very little. And then some people who have got teams already just require maybe additional advice or support. And what we're really trying to do with this national centre is to allow people to come to the memory clinic should they require it, but also to give outreach assistance to other areas if they require that as well. So I'm now going to stop sharing my screen and I'm going to hand over to Jenna Payne, and Jenna is going to deliver a presentation on practical approaches. And once again, congratulations and well done. And I'll hand over to you, Jenna.
Thank you so much, Mary, for the kind introduction. Just 2 seconds now and I will share my screen.
Perfect.
Okay. Sorry, no, 2 seconds. Just move the PC, yeah. Okay. So thank you, Mary, very much for the introduction. In our book, we cover many different areas that people might struggle with, but for the purpose of today, we thought it might be best to hone in on one and just look at enabling the mealtime experience for a person with intellectual disability and dementia. So I think we can all agree food and eating are a very enjoyable and social part of all of our lives. Many people with intellectual disability and dementia may develop problems with eating and drinking, which can be upsetting to see. And I suppose when we see them losing interest in food or struggling with food and drink, that can be very difficult for us as carers. If you are supporting someone with dementia, you may notice mealtimes becoming challenging and often a source of distress. The person may sit and stare at food on a plate. They may have difficulty recognizing what food is, or they may have difficulty holding a fork or other items of cutlery. Even if the person is hungry, they may not be able to put the steps in motion that would allow them to pick up a fork, place food on it, put it in their mouth, chew and swallow safely. So these are all things we probably take for granted ourselves. So it's understandable that a person with dementia may become frustrated or distressed or even disengaged when it comes to mealtimes. So for the purpose of today's masterclass, we hope to provide some practical information for anyone who is caring for a person with intellectual disability and dementia. So what is feeding, eating, drinking and swallowing? The terminology that we might use around mealtimes. Some people might be familiar with the abbreviation of FEDS, which essentially stands for feeding, eating, drinking and swallowing. Feeding, when we look at it more closely, is that physical act of bringing food or fluid to the mouth. Eating, drinking and swallowing then is the process, which includes preparing food for swallow, moving it to the back of the mouth, triggering the swallow and getting the food safely past the airway. So we need to look at it then maybe in a little bit more detail and understand swallowing so that we can better support the people we work with or that we care for that may have swallowing difficulties. A safe swallow requires really good coordination of a lot of sensory messages and muscle movements and can actually be broken down into 4 different phases. The first one is the pre-oral phase. So this is when you think of when we hear food cooking and when we smell food, when we see it on our plate, our body knows to prepare to eat and drink. For example, we produce saliva, so our body is getting ready. Our lips then might remove food from a fork, or we might take a fluid from a cup. This is all that pre-oral phase. We might bite a piece off a sandwich. Again, that's all within that pre-oral phase. We then move on to the oral phase. And here, this is where our lips might close and stop the food or drink from falling out. We then chew the food and break it into smaller pieces to help with our digestion and to prevent choking. And if you think about it, we then use our tongue to gather the food as we chew, mix it with saliva, and then we start moving the food into a ball and towards the back of our mouth as we move into the what's called the pharyngeal phase. And I'm not trying to overcomplicate this, it's just to get you thinking about what happens. As the food moves through the throat or the pharynx, if you take a second when you swallow, we actually stop breathing. And this is to prevent any food from entering our airway or our lungs. So at this stage, when we stop breathing, the soft palate at the back of our the roof of our mouth will actually rise, and food will then be prevented from going into our nasal cavity. Our voice box or our larynx then might move up and forward, so our epiglottis blocks off our airway, and then food can travel safely down towards our stomach. So it's quite a complex process that happens when we are swallowing, and really, really important to understand these different stages as someone is swallowing. And our goal is to get it safely to the stomach without any complications. So I suppose for people who may have difficulty with any of these stages, and it's important to acknowledge some people might have a difficulty at one of the stages we just talked about, but you could also have it across multiple stages. This is where we might hear the term dysphagia. So dysphagia is described as the difficulty moving food from the mouth to the stomach. And there is actually growing evidence and concern regarding the presence of eating and swallowing disorders in our ID and dementia population, often increased with someone's level of cognitive functioning and maybe physical disability as well. So it's important to know that it's quite a high prevalence in our population. So there are a number of reasons why individuals with intellectual disability and dementia may lose interest in eating and drinking or developing swallowing problems. Some of these include oral skills. So we're thinking here your oral muscle tone, your tongue function, your chewing function. Physical problems. So does the person have the ability to hold or use utensils or cutlery properly? Do they have the ability to maintain proper posture during meals? So these are all the things we're thinking of. Sensory problems then, so this could be thinking of, can the person even recognize food or drinks at this stage? Temperature, do they know if the food is very hot? They may have a reduced awareness of hunger and thirst, or a change in their smell and taste senses. So thinking about all these. The environment can significantly impact a person with intellectual disability and dementia in terms of their swallow. Noise can be enough to distract someone. If there's too much visual stimulation, is the lighting enough? Can they see the meal that's in front of them? Even room temperatures, if it's too hot, this might actually lead to increased confusion and distractibility. So these are all factors we need to keep in mind. Poor oral hygiene can be quite a significant contributing factor as well to dysphagia. Does the person have a dry mouth, gum disease? They may have mouth ulcers, poor dentition. These are all the things, again, around oral hygiene that we need to be thinking about. I'm sure people might be familiar with different medication side effects. If the person is on new medication, or if a dosage has changed or anything like that, this might actually affect their appetite as well as their ability to swallow effectively. And medication, I think it might go without saying, can really impact someone's level of alertness as well. So these all have a significant impact. Communication and cognitive problems, so that ability to express your needs or your food preferences. Can you follow instructions to participate in meal times? You might not remember to eat, or maybe you've forgotten that you did eat. So these all have an impact. Swallowing problems, and I suppose we'll talk a little bit more on that, and we've just gone through the stages, but someone may need to avoid certain types of food if they have any difficulties at those oral, pharyngeal or esophageal stages. Aging naturally can impact someone's skills. And then just to touch on feeding technique at the end. So if you're feeding yourself, do you have the sufficient physical ability to feed yourself safely? Or if you're depending on someone else, is that person feeding you in the manner that we need in order to swallow safely? So these are all things that we need to think about when we're looking at the bigger picture of dysphagia. And I suppose it's important to acknowledge that all of these issues can make mealtimes very stressful and difficult for the individual, as well as for the caregivers of people with dementia. And also, I suppose we need to acknowledge that dementia can vary from person to person. So these problems might look quite different depending on the stage of the person's disease process as well. So when we think of dysphagia, I suppose it's important to highlight the risks. So the presence of dysphagia in individuals with dementia can lead to serious consequences. Aspiration would be the, I suppose, big red flag that we would be drawing people's attention to today. So that is the accidental movement of food or fluid through the passages and into the lungs. If food and fluid stay in the lungs, it can actually allow harmful bacteria to grow and lead to quite serious lung-related complications such as aspiration pneumonia. And this may cause the person to be hospitalized and even become life-threatening. So it's a big one to take note of. Other risks would include asphyxiation. I suppose that's a fancy word for choking. Respiratory disease, in particular aspiration pneumonia, as we touched on there. These have actually been identified as quite common causes of death in people with intellectual disability, so a huge risk. Dehydration and malnutrition, these can lead to other serious complications in adults with dementia. In particular, when we think of someone with dementia who might not be as active or physically involved anymore, they can develop pressure wounds, if people are familiar with that. And actually, if you are dehydrated or malnourished, it might lead to impaired wound healing, which can obviously lead then to further complications. So really, really important. Obviously, it would have a negative impact on a person's quality of life. Hospital admissions we touched on, and increased cost of care because of their medical need involved. The complications that can result from unmanaged dysphagia can be fatal if we look through all of these. So recognizing the signs and symptoms is the first step in preventing complications that might occur. So I have listed here some of the more common signs and symptoms of dysphagia, in particular when I think of someone with dysphagia in our ID population with dementia. It can be difficult to spot a person having difficulty eating and drinking because the warning signs can often be very subtle. Some dysphagia signs and symptoms can be noted during or maybe after meals, and these might include things like coughing, throat clearing, a wet kind of vocal quality might be heard, especially if someone is after having a drink. You might also notice a person physically struggling with eating, so spilling food from their mouth, holding food in their mouth for a long time, or chewing maybe for a longer time than we would have usually noticed in them before. So I suppose in our population with dementia as well, fatigue can be quite a significant sign that we see, and it just indicates that the level of effort and energy required for the person is really increasing. So it can be another red flag and something to bear in mind. Over a longer period of time, then caregivers might notice the person avoiding foods, or might notice weight loss, dehydration, those recurrent chest infections we mentioned, some of which can develop into aspiration pneumonia. I suppose the big thing to say is you can help prevent serious complications in relation to dysphagia by identifying some of these signs and symptoms. And not to give my role as an SLT too much of a plug, but this is where a referral to speech and language therapy would be very appropriate. Professor McCarran mentioned in last week's masterclass the need for an annual brain health check. And ideally, I think a swallowing assessment would be carried out as part of this baseline measure of dementia, in line as well with best practice guidelines. This will just make it easier to track changes as someone's presentation progresses. And from my experience, I find it can often be behavioural changes around meal times or concerns around someone's swallow that can actually bring dementia to light. So having this baseline measure can be hugely valuable. So this is where I come in as an SLT. So a speech and language therapist plays a primary role in the assessment and treatment of eating and swallowing disorders in individuals across the lifespan, but obviously including adults with dementia. A swallow assessment might look at the safety and efficiency of all the stages of swallowing. We'd also take a look at the behaviours that are happening around mealtimes that might be impacting someone's safety. People might experience caring for someone who talks a lot while they're eating. And it's a social event. By all means, we want the social aspect of it, but talking could lead to problems if it's not promoting a safe mealtime experience. So we just need to have a look at all of these things. We would also look at the efficiency of the muscles and structures in the mouth and check if there are any abnormalities that might be affecting the swallow process. Following then the assessment, the speech and language therapist would make recommendations to support a safe eating and drinking plan. I think when people think of a speech and language therapist, often what comes to mind is modified foods and thickened drinks. And yes, that is big part of our role, but we do try to look at the bigger picture first in collaboration with other multidisciplinary team members. If food modification is recommended, the speech and language therapist will help to determine the least restrictive food texture and fluid consistency that would be safest for oral intake for the person. For some people with dysphagia, the texture of a normal diet, so what you or I would consider a normal diet, might just be to present too many risks. So the SLT will then make specific recommendations about making changes to maybe the texture or consistency of the food and the drinks to reduce the risk of aspiration and any other dysphagia related complications. But it's important to say, just because the person has dysphagia and dementia, it doesn't necessarily mean that they have to be on modified foods or fluids. It's more so that clear guidelines relevant to the person are drawn up by the speech and language therapist to maximise the person's safety at mealtimes. So in keeping with best practice, and I did mention collaborating there with the multidisciplinary team, when it comes to dementia care, a team approach is very much recommended. I think a safe and enjoyable mealtime is best supported by a collaborative team, which very much has the person at the centre. Caregivers of people with dementia in particular play a critical role in encouraging the oral intake of someone, but also in identifying swallowing problems in the person they might be caring for, because they are with them most and they would witness these signs and symptoms far more than any of us coming in on a visit or an assessment or whatever it might be. So for the purpose of today, I thought it might be useful to identify some useful strategies which promote a safe swallow and mealtime experience. Assuming there are speech and language therapy swallow guidelines in place, I would always refer to the person's care plan, and follow any diet and fluid modifications as recommended by the speech and language therapist. But these are some useful tips that I often recommend when supporting someone with dementia at mealtimes. So first of all, checking that necessary dentures, hearing and visual aids are in place at mealtimes. This might seem obvious, but you'd be surprised how often it doesn't actually happen, and these can have a big impact. So that would be the first thing I would draw your attention to. Ensuring that the person is alert and awake before, during and after their food or drink. I don't know, people might disagree, but certainly in my experience, in particular with dementia, a person's presentation can really vary from day to day or even across the day. So if they are too tired or become increasingly fatigued at mealtimes, I would even discontinue the meal and try again later when they are more alert and when it's safer for them to take some food or drink. Positioning is very important. Positioning the person so that they are upright and as aligned as possible during the meal and for at least 30 minutes after the meal. I know staff often say to me, it's very difficult to keep someone upright for 30 minutes afterwards. Some people can be quite stubborn and set in their ways, which is just a natural way to be, I guess. But it's being clever. If we can incorporate even going to the toilet after your meal just to kind of foster a few extra minutes of being upright, it'll promote someone's safety. So really important thing to flag there. The environment we did mention briefly a while ago, but it's vital and can really contribute to someone's safety at meal times. So reducing and I suppose eliminating distractions as best we can in the mealtime environment. As much as I hate to discourage talking, when someone has food or drink in their mouth, it's probably best to be avoided. And then just, I suppose, if you are in a position of assisting someone at meal times, presenting small spoonfuls of food or fluid at a time. I often even recommend a teaspoon, because this naturally reduces the volume that the person will take into the oral cavity, and it just gives them that bit more time then to swallow and clear what's in their mouth before presenting them with the next spoon. Time is very important, and I am very conscious that we're all busy people, and you know, in particular for people that might be working in a residential home, we might have something else to do or even someone else to feed, but allowing the person time to swallow and clear what's in their mouth is so important. And don't forget about communication at mealtimes. Overall, we've touched on the fact that it's quite a social event. So we do want to look for those more subtle, non-verbal, maybe communications, facial expressions, gestures, eye contact. They might be looking at a glass to signal that they want to drink. So looking for all of those more subtle communications and gestures. And pain, if someone is looking quite distressed or they're doing facial expressions to indicate pain or discomfort, we need to respond to that appropriately as well. A little and often approach is something I would often recommend. And I suppose it's just the idea that having smaller meals eaten more often over the course of the day may be better than 3 large meals a day. If a person has difficulty in concentration or has a poor appetite or changes in how food might taste, or even if their meals are taking that bit longer to eat and fatigue is becoming an issue, then reducing the volume and spreading it out across the day can work very, very well. If you are working or caring for someone who might engage in increased physical activity such as pacing or wandering, having some suitable finger foods or snacks available to them across the day can be useful, especially if they're finding it difficult to remain seated at a table to eat a full meal. So that's another handy tip. I think we'd all agree that appetizing food can stimulate the senses. So here we're thinking of taste, smell, temperature, the visual presentation to enhance someone's appetite. I would find sweet and flavoursome foods might promote oral alertness. So considering these foods that are strong in flavour, when we are presenting those with dementia in particular with meals is very useful, as they might be that bit more desensitized to taste. So those stronger flavors will provide increased oral feedback. Just to touch on as well, the idea we mentioned earlier, a sign of someone holding food in their mouth or pooling food. Often we would see an accumulation of food or drink maybe in the cheek or on residue on the tongue. I have a nice image there just to show what I'm talking about. Residue and pooling can actually put someone at increased risk of aspiration, as they might forget about it completely and swallow it at a later stage. So, and it can also contribute to poor oral health. So this is really, really important, and we need to ensure good oral hygiene. This is actually one of the leading risk factors of aspiration pneumonia in individuals with dysphagia. So oral hygiene and checking for any accumulation of food or drink is really, really important throughout the meals. I kind of mentioned earlier, if someone isn't alert or if their arousal levels are quite low, we might discontinue a meal. But similarly, if there's any significant signs of distress, it's okay to discontinue a meal and maybe introduce it again later. Just lastly here, monitoring a person with dementia's intake of food and drink is really important, especially as we progress to the mid to late stages of dementia. Nutritional supplements may be beneficial for someone who is struggling to eat or where their intake and hydration levels are a concern. A dietitian would be best placed to advise on this, but often someone I would work quite closely with and something to keep in mind. I find food diaries and things like that can be very useful as well. Okay, so there are obviously other things to consider, and Kathy will be going into some of these in a little bit more detail now in a minute, but I just want to draw your attention to a few of these. When we're looking at the point there around independence or requiring assistance, even partial independence is valuable to someone. So if the person can even bring food to their mouth with hand over hand support, that's really lovely. Someone else might benefit from you scooping the food onto a spoon, and then they might take it themselves independently. I think this is really important to draw your attention to, because as someone with dementia progresses through the disease, their ability to manage cutlery or to chew and swallow safely can diminish, as we've mentioned. So fostering any sense of independence while we can is really, really beneficial. In terms of baseline skills, and we talked about the need for having a baseline assessment, but I just want to mention a quick example here. I work with a man who was recently discharged from hospital as a result of aspiration pneumonia. And he was actually discharged with the recommendation to use a straw to reduce the pace and volume of his fluids. At his baseline, and I suppose because I have that baseline assessment done with him and I would be quite familiar with his skills, he wasn't actually ever able to use a straw. So this wasn't a viable option for him. So we had to look at alternative ways to reduce the volume and to slow down his pace while drinking. And a simple solution to promote his independence, going back to the independence, would be to take his cup that he normally drinks from and just present smaller portions of the fluid at a time. And this now is working nicely for him, and it is reducing the volume and the pace while he's drinking. So really important to think of someone's skill set. Just the point there on cueing can be very beneficial, in particular that kind of supervision and environmental cueing we can offer, but we have to think about how best to do it. Someone with dementia, again, maybe at those kind of mid to later stages, might actually benefit more from the subtle visual cue of you just sitting down beside them, eating your own meal, as opposed to those verbal cues where we might be saying, eat up, come on, take another bite, because that language might just be too much for someone depending on their stage. Someone else might respond very well to gentle tactile cues. So again, it's just to get you thinking. And just to talk very briefly on preference, one of the last points at the end of the slide, really important to remember the person's preferred foods and offer choice as appropriate. And it often becomes the way where intake can become an issue and a concern for carers and staff working with people with dementia. But where intake is reduced, healthy eating isn't so much our priority anymore. So it's okay to offer the person's favorite foods. So if the person wants to eat chocolate pudding and 7-Up all day long, that's okay. It's better than not eating anything. So it's just an important thing to touch on. And lastly, I suppose just to mention about food preparation and appearance. If we are preparing modified foods for people, it's really important to consider the appearance and to make it as appealing as possible to promote intake, and I suppose to promote someone's interest and motivation in eating the meals so that their intake will be increased. Looking at the three of these pictures, I know which one I would find more appealing. So just to kind of give you a little bit of something to think about there. So before we go any further, I might just show a very short clip to put what I've said in context and to get everybody thinking. This lady is Rosie, and she is a lady in the mid stages of dementia who I have very kindly been given consent to show this little clip of. Have a think about her mealtime environment and ways in which we might modify her dining experience, knowing she has a diagnosis of dementia. So just be thinking about noise, environment, visual setup, and maybe her positioning as well. And then Kathy will take over. So we'll just play Rosie. Okay.
So I'm going to talk us through some of the changes that we typically see at mealtimes in the early, mid and late stages of dementia. So in the early stages, changes tend to be quite subtle. And this means it's really the carers who are very familiar with the person who are likely to notice or recognise changes that are happening. Some of the changes that are good to be aware of at this stage include the person may occasionally forget to eat or drink. They might need more prompting and reminders at meal times. We might see the person reducing the variety of food that they may once have enjoyed. We could see changes in their dining skills, their baseline dining skills. So they might now have difficulty using utensils or maybe scooping food onto utensils. And looking at some of the possible reasons for this, at this stage, just looking at the visual perceptual difficulties that people can have. It's a very common symptom we see, and it means that, so visual perception is that although the person can see perfectly well, their brain is misinterpreting or not making sense of what's being seen. So for example, if you remember back to Rosie having her lunch there, she was eating beans in a white bowl, and that was on top of a tablecloth, which had a really busy pattern with orange flowers dotted all over it. So for someone with visual perceptual difficulties, it would be very difficult for them to distinguish the beans from the tablecloth. Another example we often see is food being presented on plates that are the same colour as the food. And you'll see that in this example on the slide there, where there's a slice of white cake and it blends into the colour of the white plate. So there are really simple solutions to these problems. In Rosie's case, the solution was to get rid of that patterned tablecloth, and instead we used a plain block-coloured table mat. So when serving food, think about the colour of the food and the colour of the dish or plate you're using, and try and use contrasting colours so that the food stand out. And this can really help a person with visual perceptual difficulties. Another issue we see a lot is tables, chairs and flooring all being of the same colour. So you'll have a wooden floor, a wooden chair and a wooden table. And for a person with visual perceptual difficulties, the chair then is blending into the floor and the table, and it can make it very difficult for someone to see where the seat starts and ends. I suppose an example of this, I was working with a lady whose caregivers were finding it really hard to encourage her to sit down at the table. And in the end, we figured out that she couldn't actually distinguish the chair from the floor. It was a grey chair and a grey floor, and she wasn't actually able to see the chair. So in her case, what we did, we just changed the colour of the chair, and that helped her then orient herself at the table. I think it's a good awareness for us to have, because the situation with that lady was that carers were starting to think that she was having behavioural issues at meal times, and in reality it was an issue that was explained by her visual perceptual difficulties. So looking at a couple of solutions to this issue, one would be to maybe change the chair colour, or just put a contrasting block colour cushion on the chair. Using a contrasting block colour tablecloth could also help, and it just defines each object by colour against the background of the floor and walls. And then another big issue we come across in the mealtime environment is the issue of noise. And it isn't always obvious to us, because I think we all have slightly different thresholds of what noise will tolerate. But what might be acceptable day-to-day noise level for us can be really distressing and disorienting for a person with dementia. We know that often changes in the person's presentation at mealtimes is noticed in the day centre and in residential settings too, where canteens and dining rooms can get really busy and noisy, and it can really impact the person and cause them to become anxious and distracted and distressed, and impact their ability to eat and drink. So running quickly through some common noise issues we see in some solutions. Going back to our lovely wooden tables, when we're placing plates and cups and cutlery on wooden tables, it creates a lot of clatter and background noise. So a simple solution there is just having a table mats or tablecloths that will absorb the noise. just bearing in mind the visual side of that as well, to use the block colours to contrast against the tableware. Another thing we see are chair and table legs scraping on the floor when they're being moved. A really cheap, easy solution is fitting felt pads under the chair legs and table legs, and that can help with that issue. What's also really common is we see the TV and radio on in the background while the person's eating. The simple solution there: turn off the TV and radio at meal times, protect that time, and keep it a nice, calm time and space for meals, and just minimizing conversations and chatter, because that can also increase the volume in dining rooms. Another solution would be to consider having an alternative dining area for people with dementia when noise is an issue, or having staggered meal times. So we did do that in one of our day centres, where people just weren't managing in the really big, busy, loud canteen. So a smaller dining room was created for those people, and it really helped them, provided that calm space where they were able to focus on their meals without distractions. Another important consideration for a supported mealtime environment is on the subject of posture. So in the early stages, the person might now be experiencing changes in their ability to maintain a sitting position, an upright sitting position. And when you combine those physical changes with perhaps the visual perceptual difficulties that might be happening, they can really impact a person's eating skills. So the task of eating is highly complex, and so we need that ability to be able to reach and grasp a spoon, for example, to use the other hand to stabilize the plate while we're scooping food onto the spoon, and then to bring the spoon to the mouth. And that's before we even consider any chewing or swallowing skills. So another important thing to consider is that, and to remember, I suppose, is that when we're looking at posture, even before a person might develop dementia, they often already need additional postural support at meal times. So as Jenna said, the best position for eating is sitting in an upright, aligned midline position, and where we're facing forwards and our body is supported on the seat surface and our feet are stable on the floor or a supporting surface. And having that stable sitting position helps us use our hands for the intricate fine motor skills required for the task of eating. We also need adequate muscle tone to be able to sit, as well as the ability to hold our bodies upright against gravity. And muscle tone also affects the tongue and its ability to move foods and liquids in the mouth, and with the swallowing process, which Jenna has discussed. Also, when we consider the physical presentation of people with Down syndrome, they typically have low muscle tone and tend to be short in stature, and that can also influence their sitting position at meal times. So just looking at these images here, in the first image, you'll see the little man on the blue seat the seat is too high for him, so his feet are dangling and they don't have a stable base of support. His seat depth is too long, so his back isn't reaching the red backrest for support. The chair doesn't have armrests, which can also provide support. So here he isn't well supported at all, and it means that he's going to be using a lot of energy in trying to stay balanced and upright. And what we're likely to see then is that he'll start sliding off the seat or slumping, and it'll be much more difficult for him to use his hands to, for example, grasp cutlery from that position. Then in the second image, the table is too high, so that's preventing him being able to reach the food. And if you remember back to Rosie, that table was also too high for her, actually, and she was kind of slumping on the top of the table. So what we're looking for at this stage is to give appropriate postural support where needed. And this might mean changing to a chair with arms or to a lower chair and table, putting a cushion behind someone's back to shorten the seat depth and give them some back support, and making sure their feet are well supported. And then moving on to the middle stage, what we might expect to see then is that the person's ability to perform activities of daily living is much more noticeably reduced. The person's probably going to need assistance with eating now. They might not be able to communicate that they're hungry. we'll see a reduction in their baseline feeding, eating, drinking and swallowing skills. And that's why it's really important to have that baseline assessment that Jenna talked about, so that we can really compare changes we are seeing against the person's baseline skills. And this then can help us plan what supports the person might need at mealtimes. In the middle stages, we're also seeing a deterioration in the person's motor skills becoming much more obvious. And they're probably struggling now to maintain that alignment in sitting. And that's even with a more supportive dining chair. And hand in hand with that, we're seeing reduced mobility and a bit of difficulty with transfers. So at this stage, we're now seeing the person needing a standard type wheelchair to mobilize for short distances. And at this point, we're often recommending that the person use their wheelchair now at the dining table, because this can provide much better support as it's been measured for the person's size. So it'll, fit them properly, which will provide a more stable surface for them to sit on. It's also easier to position the chair into the table because it can be wheeled in and get the person in a better position at the table, rather than the situation we often see of carers trying to push someone into the table in a generic dining chair, which can be difficult. So then just quickly looking at adaptive equipment, there's lots of adaptive equipment, mealtime equipment out there, but just some things we would use quite a bit would be foam handles to support someone's grasp, using plates or bowls with built-up sides to help them with scooping. Dyson matting is great to stabilize plates and bowls. And again, just always considering the color of bowls and foam handles and mats, so that we're choosing items that give the person the best chance to see the meal or the cutlery and to be able to use the equipment and maintain their skills for as long as possible. One thing I would say, and Jenna mentioned it earlier, is that in the middle stages, as the person's dementia is progressing, just bear in mind that their ability to learn to use a new piece of equipment may be limited. But I do think it's always worth trialing a piece of equipment, because you just never know, it might work. And if it does, then it helps that person maintain the skill for a bit longer. And then finally, in the late stages, we see the person becoming fully dependent at mealtimes. At this stage, they might not be able to recognize food, and so they have no understanding of what's being expected of them regarding food. They might forget how to chew or swallow, and we see food being pocketed, and we usually see weight loss now. Also, the person's now more than likely not able to weight bear, and they're going to be fully reliant on a wheelchair to mobilize and need assistance to change position and maintain an upright sitting position. So at this stage, because the person needs even greater postural support at mealtimes, we typically see them moving from that bog standard type wheelchair to more specialized seating. And this type of seating can be customized to the person's size and specific postural needs. So we can anchor that and stabilize their pelvis, and then that helps align their upper body. And we can give trays, that help somebody rest their arms when they get fatigued, as well as for use at mealtimes. And then eventually, as the disease becomes more advanced, the person may be spending more time in bed and may need to eat in bed. And in that situation, a profiling bed allows the backrest to be elevated to support the person in a sitting position for 30 minutes after the meal, as Jenna mentioned. And, if possible, we do say, we prefer somebody to be in the supportive seating of a wheelchair or perhaps a comfort chair, but we do recognise that people do get to the stage where they might not be able to sit, and then at that stage they do have to eat in bed. So we hope we've provided you with some useful tips and strategies, and I suppose realistically we could be here for a lot longer talking about this subject, but we did our best to try and highlight the common issues we see coming up, and just some food for thought, that supporting someone with Down syndrome or intellectual disability who has dysphagia and dementia does present a set of unique and difficult challenges. we would highlight, when you're looking for changes, to monitor things like deterioration in chest status, the signs or symptoms of aspiration, looking out for unusual eating and drinking patterns, and looking out for weight loss, and then consulting with the appropriate medical team as appropriate. And just to say, with the right training, knowledge and support, caregivers and staff can significantly enhance the quality of life for someone with Down syndrome or intellectual disability with dementia. And for more information on the topic and other practical strategies, we hope our book, A Guide to Dementia Care for People with Down syndrome and intellectual disability, will prove useful. And thank you very much for listening, and we welcome any questions or feedback.
Thank you very much to Kathy and Jenna. That was really informative and excellent. And I know we could have talked to the subject for a lot longer. And I am concerned about the time. And there are some questions that have come in and that were sent in prior to the presentation as well. So I'm just going to move quickly with them. I'm going to introduce the other panel members. I have introduced Kathy and Jenna already, but I want to introduce Geraldine O'Callaghan. Geraldine is also from COPE, and she's a candidate advanced nurse practitioner in the older adult and people with intellectual disability. And I also want to introduce Lynn Galligan. Lynn is a clinical nurse specialist in dementia at the Daughters of Charity Service and has been the clinical nurse manager in the really state-of-the-art dementia homes that there is at the Daughters of Charity Service for supporting people with more advanced dementia. And I'm just going to move to you, Lynn, and I'm going to ask you something pretty quickly as this has come in. And this was in relation to something that Kathy and Jenny both spoke about, and that was in relation to food thickeners and how much food thickeners should be used. And we have a gentleman who refuses to drink when they're at it. And have you any tips around that, Lynn?
Yeah, I suppose, Mary, and hello to everybody. From our own practice here, we would be quite, I suppose, lucky that we have speech and language therapy.
I think we're losing Lynn there. I think we've lost Lynn.
It's the same as a prescription, so it must be prescribed.
Sorry, Lynn, we just lost you there. So can you repeat that?
Oh, sorry, yeah. Just in relation to the thickener, Mary, just it's a prescription, so it will need to be prescribed by the speech and language therapist. Usually what we would do is we would monitor somebody who is maybe showing signs of dysphagia until the speech and language therapist comes out and assesses them for their dysphagia, and then they will guide us on how much thickener needs to be added to a fluid. I suppose if the person themselves, if he's refusing the drink with the fluid in it, there is other options as opposed to fluid itself. You could offer him soup, which could be used, counted as fluid intake. Fruit juices, there's custard, there's ice cream, there's different options there to, I suppose, as Jenna and Kathy have already said, to try and interest someone back into eating food. It's not pleasant. I'm sure anybody that thickens food, it's not the most pleasant, but there are options there to get fluid.
Okay, we're losing a bit of sound there with Lynn. Yeah, your connection is slightly off. Yeah, that's fine, Lynn. Okay. Just in relation to a second question, Lynn, for you, and that is in relation to the use of food supplements if a person isn't able to eat sufficient quantities. And can you give, that has come in, any advice on that?
Yeah, for that, Mary, we would refer people to a dietitian. So before we refer somebody to a dietitian, we have at least a nurse's assessment of what exactly somebody is taking in from a food perspective. That way the dietitian themselves can gauge how many calories that person is taking in. And prescription again for food supplements, if there is a need for food supplements. There is some over the counter supplements like Complan that you can use for people as well if they're not eating enough. But again, you need to have evidence as to what exactly they're eating. You know, Is it that they're eating sufficient amounts just over a longer period of time, or is it that they're not taking in enough orally?
Okay, and one
So
final
again,
question, Lynn, which probably relates to this, and hopefully we'll be able to keep in contact. And this is going to be a subject in its own right, but somebody at a very advanced dementia who's not able to orally eat or drink, and the question came in relation to the use of peg feeding for people with advanced dementia. And as I mentioned, we will be running a masterclass in relation to more advanced dementia, nutrition and hydration later on in this series of masterclasses. And just to say, I suppose I'm probably part assist with that answer, that there's very little evidence to support the value of tube feeding for people with an advanced dementia. And rather than it promoting comfort for people, it can end up promoting discomfort, because as Jen has pointed out, you were looking at muscle weakness happening right throughout the body. And so people may regurgitate even in food who's presented in that way, and rather than it being a pleasant experience for somebody, it may become unpleasant. But nonetheless, every person is individual, and these decisions need to be made early in the disease process at a time when there's not charged by high emotion and when there's a crisis. So I suppose we'll talk a lot in later classes around advanced care planning, and there's some of the important issues that does need to be discussed, because as dementia progresses, as Jenny and Kathy has both pointed out, people will lose the ability to swallow. You've been working in supporting people with very advanced dementia, Lynn. Have you anything to add to that?
Yeah, Mary, I totally echo what you've just said. And I suppose what we would...
We're losing Lynn there.
Feeding, as Jenna and Kathy have already...
Okay, Lynn there.
30 minutes prior to eating and then after eating, and then ensuring that it's little and often, and just ensuring that when you are feeding someone that they're not distressed, and to make it as comfortable as it can be for the person with an advanced dementia.
Okay, Geraldine, I'm going to also perhaps get you, thank you very much, Lynn. Geraldine, I'm going to actually probably get you to probably comment on that as well in your role as a clinical nurse, candidate advanced nurse practitioner, and your experience in working with people with advanced dementia.
Yeah, thanks very much, Mary. Yeah, I just, thanks so much, Jenna and Kathy. That was a really good presentation. I think that, food refusal overall can be a natural stage of the dementia journey. And I agree, like you, Mary, I think these conversations probably should happen a lot earlier with the person that carers are supporting and their carers involved as well, particularly around the use of maybe nasogastric feeding for maybe acute illnesses versus the use of PEG for a person. And most research that is out there would tell us that it doesn't actually increase the quality of life or have better outcomes in relation to malnutrition for people with dementia. So therefore, it really wouldn't be really supported to kind of have a PEG for somebody with more advancing dementia. But again, people, and I know there is research out there that would say that maybe the use of NG tubes for maybe kind of more acute illness phases might be more beneficial, but not as a long-term use.
Yeah, and it really is. I mean, the big question is here to know that if people survive, that this often becomes an inevitable part, and it's having those plans made in time, looking at the person's will and preference, if we can make them early enough and in conjunction with family. But that conversation does need to happen, and we do need advanced plans in place around some of these issues to guide care going forward. But again, every person is individual, and this we need to look at what the evidence for our interventions are, and then have a discussion around those that evidence with respect to guiding care. The second question, Geraldine, just before we finish up, and that is, can medication specifically used in the treatment of dementia for those with Down syndrome, can they affect people's swallow or feeding abilities?
Well, I think I'm a firm believer that most medication can have an impact on somebody with dementia who has a swallowing, like for their swallowing and feeding, you know. And I think when we look at medications specifically that are used for dementia, and also those that are possibly the people are on due to other illnesses associated with their dementia, it can have an impact on, you know, Jenna mentioned earlier, their alertness, fatigue for the person, particularly around meal times. I think in relation to medications that we should look at, you know, the times that medications are given, but like all the panelists have said, really in relation to how much the person is eating in any one meal. Should it be shorter meal times and more spread out throughout the day? I think polypharmacy still plays a large impact for people with intellectual disability and dementia. And I think we should all consider that in our practice. And sensitivity to medications are huge for our population as well. And we really need to incorporate that. I know we're running out of time and we could go on all day about medication, but the form of medication that it's delivered in as well is really hugely important. And it does have a significant impact every day for people with dementia, with their meal times and their swallowing difficulties, whether that be a large tablet form, liquid form, even in crushed form as well. So medication and how we deliver it and how we support people with it, it does have a huge impact on swallowing and feeding abilities.
Yeah, lovely, Geraldine. And I think we could have a full masterclass in terms of medication, and we may look at that indeed going forward. One further question that has come in, and that is there a specific time of the day that's better to aid digestion in terms of meal times? And probably, I think, going back to what Jenna and Kathy and the panel have said, really, it is about when is the person most alert and when is the person most hungry. And you can really see that. But very often in dementia, particularly as dementia progresses, you're looking at giving small amounts of food on a regular basis rather than giving one very large meal, which is often very difficult for somebody to tolerate. So you're really looking at what are the indications for the person that this is a good time, that they're alert, that they're upright, that they're awake, and that they appeared hungry. And again, going back to what Jenny and Kathy have said, it is about small amounts on a regular basis. I need to close it there because we have run out of time. I want to thank our presenters for today, Jenna Payne and Kathy Ware from Cope Foundation, Geraldine O'Callaghan also from Cope Foundation, and Lynn Galligan from the Dorset Charity Disability Support Services.